Welcome to LIMBWatch, a special series from Diabetic Foot Files dedicated to science, strategy, and collaboration behind limb preservation. Every limb tells a story, and every saved limb represents a patient whose future has been changed through early detection, multidisciplinary care, innovation, and persistence. Today's guest, we are honored to have Dr. Shilpa Rajan Mulki, an internist, pathologist, and CMC Galore trained diabetologist and lead of the Diabetes Foot and Wound Clinic at Lions Site First Eye Hospital in Nairobi, Kenya. Dr. Mulki specializes in multidisciplinary limb salvage and the management of complex diabetic foot disease. She is deeply committed to advancing health equity by adapting cutting edge evidence based limb preservation protocols for resource limited healthcare settings, demonstrating that world class diabetic foot care can be achieved regardless of the available resources. Her dedication to excellence has earned her international recognition, including the best oral presentation at the King's Good Summit 2025. That's amazing. She also serves on the executive leadership teams of the Kenya Diabetes Study Group and the American Limb Preservation Society Health Equity Committee, helping shape the future of diabetic foot care and limb preservation both regionally and globally. Beyond her clinical and leadership roles, Dr. Mulkey is quite a passionate advocate for sustainable healthcare, actively researching ways to reduce the environmental impact of clinical practice while maintaining the highest standards for patient care. So, welcome, Dr. Mulkey.
Thank you very much, Dr. Gabrielle. It's a pleasure to be here. I am sincerely honored. Thank you for having me.
Yay. Okay, so Dr. Mulkey, can you tell us about your journey to diabetology and what led you to develop a special interest in diabetic foot complications?
Sure. Like I said earlier, I developed a liking for smelly feet. Take that as you may. Uh, and I did my diabetology in Christian Medical College, Vellore. I had gone there to accompany my then husband for him to do his spine orthopedic surgery, and I came across the endocrinology and diabetes team, and well, I applied to be part of their team. I enjoyed my initial stint there for the first 6 months. Then I joined the fellowship program. In that fellowship program is where my professor, Dr. Nihal Thomas, and my colleague, Dr. Riddhi Dasgupta, and a couple of others, Dr. Nitin Kapoor, Dr. Mahesh, all of them kind of somehow nudged me in the direction of seeing foot-related complications on a more regular basis. It was their escape, but I somehow was happy to see these patients because there's a joy in seeing them get better over the next few weeks and actually seeing a wound heal. Being a diabetologist, yes, we do look at numbers. The HbA1c is important, the LDL and the TG is important, the ECG is important. But when you see a foot wound go from huge, complex, almost requiring surgery. The patient undergoes an amputation, but within a few months walks out of there with a properly offloaded foot. That's the training that I got when I was at Vellore, and that's what inspired me. I felt, okay, I need to do this more often because in my MD training, I didn't come across that. Diabetic foot was something that was taken care of by the surgeons, and that usually meant amputations and nothing else. Here, I learned about neuropathy management, peripheral arterial disease management. Basically, limb salvage and offloading were the key things that I learned at CMC Vellore. So that's
Wow.
what took me to that journey. It was smelly feet, hot and humid air did not make for a good mix. But then when the air became smellier, that became interesting to me. Wounds healing was gratifying to see wounds heal.
Oh, awesome. So, what was the moment that you realized diabetic foot care needed to become a major focus in your clinical practice?
It's the gap. There is such a gap. When I was working in India as an assistant professor in my medical college. I realized that, okay, no one's dealing with it, so let's start teaching my students. So that was when I realized, oh my God, there's a huge gap. I didn't learn about it. Now these kids are not going to learn about it, so let me start teaching. Then I moved back home. I moved back to Kenya, Nairobi, which I call home. And I came here, and there were very few practitioners, maybe one or two. So we have about 4 to 6 podiatrists here. When I did my voluntary stint here at Lionside Plus Eye Hospital at the beginning. And again, there's a gap. But
Mm-hmm.
there was potential to fill that gap. With the podiatry, he was the one who said that we needed multidisciplinary care, and I'm interested. Do you want to work together? And I said yes. And then I became employed at this hospital, and we started seeing more and more patients, and the gap is closing. And I'm grateful because at least from here, it's not just me treating patients, finding that I'm able to teach people through KDSG, through various various forum, patients who come in and with their nurses because they come from far. So I teach them. I teach the nurses as to what to look for, what needs to be done, so that they don't just manage that one patient. If they see any other patient, when they go back to their clinical practice, whichever village, county, town that they go back to, they're empowered a little bit more to open up their eyes and see warning signs plus signs of the red flags for referral. I think most of us have recognized that gap. That's how we come into it. You're like, why isn't anybody doing this? And why isn't anybody doing that? And can we do it? If I can do it, why can't anybody else? So let's teach
Mm-hmm.
whoever's interested. And
Oh,
yeah,
wow. I already love that insight. So many amputations are considered preventable. What are the biggest missed opportunities you see that lead patients down to the pathway towards limb loss? I think we kind of covered it a little bit, but
yeah. So it's just the red flag signs. It's that we don't look for preventable causes. It's that we don't even know that there are preventable causes. I have patients I have patients coming in who have never had a neuropathy assessment in the past 25 years of them living with diabetes. Not once has any clinical practitioner talked to them about taking care of their feet. Not one practitioner has said, don't expose your feet to the radiator, to, the
hmm
stove warmth. Because it gets cold here sometimes. Nobody says any of that stuff. There are many people who come from rural areas. It gets
hmm
cold. The practice is to sit in front of a stove. And nobody tells them that this can be harmful for you. Nobody tells them don't dip your feet in hot water without somebody else checking it. Nobody says, okay, you'll have pain when your calves when you walk. That's nothing. That's old age. But nobody thinks about peripheral arterial disease. There isn't enough training. So picking up prevent screening for peripheral arterial disease with simple clinical methods, and screening for neuropathy and patient education in a simple card form. Even from Ideal UK, they have a beautiful card which is in 3 different skin tones.
hmm
It says act now, so I don't know if I've shown you the graphic in the past, but it's a beautiful graphic to show that if these things happen, if there's an accident, if there is callus, if there's this, that, you need to come immediately and show it to the clinician and they'll be able to handle it. So, yeah, I mean, those are small missed opportunities, but not delving into the past, but taking it onto the future now and making sure that whoever I come across will know about these possible missed opportunities and tell them to and insist that they do right by the patient.
That's right. That's so beautiful saying do right by the patient because that is absolutely true. So, how often should a person with living with diabetes have their feet examined? In your opinion, what should the examination include?
Okay, there's something that I tell every individual living with diabetes who comes to me for consultation, or even just friends and family. Look at your feet before you go to sleep,
Oh,
right?
nice.
We
It
wake up
rhymes.
in the morning.
It
We wake up
rhymes.
in the morning, and yes, you wake up in the morning and you look at your face as you wash your face and you brush your teeth, if you brush your teeth, or if you're brushing your dentures, whichever the case may be, you're standing in front of a mirror, so you know exactly what your face looks like. If I have a new zit, I'm going to be like, oh my God, what is that? Similarly, if a person takes a look at their feet every day before they go to sleep, they understand the contours, the discolorations, the common moles that they have. And when they see that something is different, is when now they can come to us as clinicians and get those evaluated. Whether it's a color change, whether there's a swelling, instead of fiddling with it and doing bathroom surgery and poking about with safety pins, they can come and show us. So I usually tell them every night before you go to sleep, yourself or the caretaker, or if it's a couple, I tell them to examine each other's feet. Like, yeah, like I said in the beginning, I seem to like smelly feet, but maybe partners will look at each other's feet and just tell them what's going on with them. It's helpful. If not, a mirror helps and foot selfies
Mhm.
help. But yeah, I mean, lighting and all of that, especially between the toes, looking
Mhm.
for new molds. So the more you look at your feet, the more you get to know them, the earlier you pick up abnormalities and you can come and show them to us. So skin color changes may not be evident in everyone that we come across, but when you know your foot enough, you will know that there's a difference.
I
So
like
yeah,
that. Did you
yeah. So
come up
color
with that?
changes and so
Did
which
you
one?
come up look at your feet before you go to sleep?
Yes.
Okay, so yeah, Dr. Mookie, this is her trademark. I don't know, phrase.
Tagline.
Yeah, yeah. So Dr. Mookie says, look at your feet before you go to sleep. I am so feeling that. So yeah.
I love it. I love it.
Yeah,
It sounded silly in my head, but it works. So then everybody laughs and they might remember. So I'm thinking, okay, that might just work. So run
that
with it.
works. That works perfectly. That's your tagline, your trademark line. So, what
Yes.
are some of the warning signs patients should never ignore regarding their feet?
Okay, so in cases where there is no dark skin tone, then discoloration, whether it is reddish discoloration or whether it is darker discoloration, a purplish hue in over Caucasian skin, even in a dark skin tone, any difference in the tone, it's important for them to come and get it evaluated. Even a spot that looks more discolored than it used to before needs evaluation. We do ignore, not even ignore, we don't know. So even in dark skin tones, melanomas are very common, but we don't pick them up. And if we do pick them up, we've picked them up too late because they've presented systemically as well. So any change in discoloration, any swelling, any clawing of the toes. So that's another thing I've started telling patients of late because I learned how to do flexitinotomies. And I have been telling them if you see that your toes are scrunching up before it gets too late, please bring that to my notice if I haven't seen myself or if you've seen it in a family member and they're living with diabetes so that we can do flexitinotomies and prevent ulcers. Another thing is to check their temperature, the temperature of their feet, both feet with
Mm-hmm.
the back of their hands, or even with an infrared thermometer if they can get one. And most of the times they should be able to manage. And if there is an ooze, there's any new wound, I tell them to most importantly dust out their shoes before they've worn them and after they've worn them as well. That
Right.
also helps to maintain foot care, even moisturization. So the warning signs are discoloration, any pain, new pain in the
Mm-hmm.
calf or anywhere over the foot needs to be seen by the clinician. Any blisters also need to be seen. So there's a from Ideal UK. In fact, Gabby, I'm going to send it across to you. It's really helpful. So it's any accident, any change in the coloration, any new pains, oozing, temperature changes, or any wounds. Those are the warning signs. But claudication pain is also something I ask actively. And I
Mm-hmm.
tell them, if you do develop these things, you must come to us as soon as possible and highlight it. If you're not coming to me and if you're going to a different diabetologist, highlight it to them, they will know what to do even if the clinician doesn't ask. This is you and your body. And even if us as clinicians, if we end up missing something, it is you to suffer with the consequence. So you have to be cautious about the screening. So I tell them it's head to toe, look for this, look for that, etc.
That's really, I really like that it seems like you're very passionate about keeping your patients fully informed and educated so that they can make the best decisions for themselves. So I really appreciate physicians like that to do that for the patients. So thank you. Like no gatekeeping, you know?
No, no, no. There's no reason for gatekeeping. We as
Mhm.
clinicians, some of us have extremely busy OPDs, some of us don't have that busy OPDs, but communication could be a problem. So even if I convey and if they go somewhere else, they should know what needs to be looked into.
Mhm.
They may go to a general practitioner who may not have the knowledge and it may not even may I can't expect everyone to know everything. So for them to, so I have a screening tool that I use. I call it Cornea to Callus, and we're putting it together here. So I tell them annually, these are the things that must be done. Wherever you go back to your village, you go back to your town, you stay with me, you go back to another diabetologist. Even patients that I see per foot and wound here, I give them the screening tool and I tell them, go back. Make sure that at least once in a year, your doctor looks at this. It has vaccination advice. It has head to toe screening advice. So get your eyes checked annually, get your lipids checked annually, your heart, etc., etc. It helps. Involving the patient in their care to tell them what can go wrong and you want to have a good quality of life is very important. So if the clinician misses it, at least the patient catches hold of it and asks.
I
And
love
it
that.
helps. It really
Yes.
does help. Yeah.
So Dr. Mulki, why do you think so many patients wait until a wound appears or becomes severe before seeking medical attention?
There are two there are two answers to that mainly. One, it's clinical inertia from the patient's perspective, and the other one is the clinical inertia from the clinician's perspective. So when it comes to patient's perspective, they some of them are aware that individuals who live with diabetes are at a higher risk of amputation and limb loss. So they fear, and
Mm-hmm.
they don't know where to go to, and that's where the whole Alps directory comes together, and it's going to be such an impactful tool to understand where a patient would like to take care and would get proper care for their diabetic foot, right? That's
Mm-hmm.
one aspect of it. Here a lot of the times it's affordability,
Mm-hmm.
sometimes it's cultural stigma. So there are places where you'll be told that it's witchcraft and it's going to get better when you do this and when you do that, and just stay, nothing's going to happen to you. When this person stops wishing voodoo stuff on you, it's going to go
Oh
away.
my God.
I have heard. Yes, yes, it's still there. It's still very much there. And you would be surprised. These are parents of kids who live in the city, who live far, the parents live far away, but then that stigmata, the culture of these things is still prevalent. It's a prevalent practice. So education is extremely important. Now, when it comes to the clinician, it's a referral pathway. If there's a proper referral pathway in place, like, okay, I'm aware that NHS and I know NIH, the American system, do have clear referral pathways. Here and in many other places, in many other low to middle income countries, there are referral tiers that do not work. So they're
Mm-hmm.
on paper simply. I have struggled to find a good plastic surgeon. I have struggled to find a good vascular surgeon who
Mm-hmm.
is happy to interact with me and work together with me in a multidisciplinary manner. But I have found them now. So getting that in place in an individual clinic like mine is a standalone clinic as part of an eye hospital. We'll get to why I'm in an eye hospital in some time, I guess. But part of the eye hospital is my wound clinic, and my ophthalmologist surgeons do not care about what happens in the feet, and I can't blame them because I don't know anything about what happens in the eye. But it's that from a clinician's perspective, we feel like, especially nurses who do the wound dressing, they say it's going to be fine, it's going to be fine, it's going to be fine, until somebody from outside the family comes and says, no, this is not okay, please take them. By the time they come to us, they sometimes need surgical intervention, or sometimes it's a simple matter of a wound that has not been offloaded, it just needs offloading, and so on and so forth. So it's clinical inertia on both ends. And that's why it becomes severe until we have to now admit the patient and, surgically intervene or
Mm-hmm.
even amputate, which makes me very sad. It happens more often than I'd like, much more often than I'd like. And maybe one day it'll change.
Yeah, hopefully. Yeah, I think we have a little bit of similarity because we're like both from like low resource countries. And yeah,
Yes.
money plays a huge role. I didn't know about the voodoo thing, but I can definitely see that. I could definitely see that. But it's usually from my patients, it's like money, and like the
Mm.
fear and money. And
Yes.
it shouldn't be like that. And just like I thought that was so nice that you said you found a group of people of different
Yes.
specialties to work with that actually, you can actually refer, trust. I did not find that when I was there, but that is so amazing to know. It makes a difference because you want to be able to refer somebody and be sure that the doctor has the best interest at heart for that patient. They're not just gonna like,
Yeah.
play the patient off. It, because patients tell stories. They tell stories of how they got their first amputation and what happened. And it seems like it's just like sometimes the person doesn't care if they didn't listen to them. They played off their symptoms, things like that. So I just listen what patients tell me, and I'm like, oh, okay. But I
Yeah.
really think that's
And
amazing.
no, and you feel so helpless because you don't know until it took me 4 years to kind of find a team that I can now call up and say, what do you think? And they'll be like, no, you manage. We will let you know when it's the time to send over to us and stuff like that. It trust
Wow.
is a big thing amongst your team. Building that is a little difficult. You get burnt a little bit, but then you get there
Hmm.
eventually.
Yeah, no, I totally agreed. It's so nice that you found it. But you said 4 years. It does take a while, especially if you have like good standards and
Yes.
care for the patient. Yeah, it does take a while to find a good, trustworthy team. Okay,
Yes.
so how do you how do you think that healthcare systems worldwide are doing enough to identify patients at high risk before ulcers occur? Do you think that the healthcare
Um,
systems are worldwide doing that? Helping?
No, I think thus far the healthcare systems have been more actively involved in proactive care. I mean, reactive care.
Okay.
It's about putting systems in place to take care of patients that already have problems. I think what the worldwide healthcare systems require is to shift to a proactive care wherein we put more a higher budget or invest a higher budget into prevention and screening and training and resource allocation into places and making things easier with what do we say? We have a lot more resource and machinery and IT to be able to do telemedicine. So we need to be encouraged to use modern technology to become proactive and help out patients and people who live in the most rural of areas and
Mhm.
doctors who live in the most rural areas and clinicians and nursing staff who live in most rural areas. I think we need to empower them to become proactive rather than be continuously reactive. I think that will take some time to change. And I think it starts from our education systems and not just the healthcare systems as such. Right from med school, we need to be taught that. It was never taught that way for me. But
Mhm.
it's something that has slowly come in of late. Like, why are we dealing with complications? We should be dealing with prevention. We should be investing far more in prevention of progression of complications and even prevention of complications completely in regards to diabetes. So I think that is something that can be worked on. And it could make a huge impact on how health economics behaves in a country as well. If you think about it, most of our patients living with diabetes and diabetes related foot complications are in their most productive age group. And it will impact the economy when they have less, like they're not able to work, they're not productive. If we're able to take care and prevent ulceration, diabetes related foot complications much earlier, it would mean that we have to spend the country as the public health system, let's put it that way, the public health system would have to invest a lot less in amputations. They would just have to invest in possible offloading devices, which make sure that the person remains productive. And that means that the health economy of the particular country or the nation will be better.
Oh, wow.
I'm not a finance person, but I think that this is something I
Yeah.
hate numbers, but I think it helps to. I mean, I've heard this from a lot of people, and it has worked in a few countries.
Mhm.
Putting preventative planning in place is very impactful.
Mhm.
So I'm hoping that that's the direction in which it will go in eventually.
Okay. From your experience in Nairobi, what are some unique challenges faced by patients with diabetes when it comes to preventing foot complications?
I would say unique challenges faced. I think it's stigmata, the
Mhm.
stigma of having diabetes, and then the lack of knowledge that we have that, oh, diabetes can impact the feet. Oh, diabetes can impact the eyes. Is that true? I thought diabetes only causes kidney problems, or I didn't even know
Mm.
diabetes causes kidney problems. Then you have the people who say, I have kidney problems. I don't have any problem in my feet. And then you look underneath and you look at the plantar aspect and there are calluses all over. And then if you ask them, what do you do for the calluses? They say, I dip it in hot water. So it's the lack of
Mm.
diabetes education that we are slowly trying to impart through clinicians also. I think
Mhm.
that's a challenge. I don't know if it's a unique challenge. No, it's not a unique challenge. I can't think of a unique challenge other than that as of now.
Yeah.
In India, it's barefoot walking. That's a very, very, very common practice. Barefoot walking within the house, especially,
Yeah.
and injury. Poor
Yeah.
footwear, probably, but that's not unique. But that's
Yeah.
pretty global. Gabrielle, you're wearing Crocs right now.
No, I don't. I've never owned a pair. I've never owned a pair. My feet do not do well with rubber. Yeah, I never owned
Yeah.
a pair. I didn't understand the rave about it. So sorry, Crocs. But I didn't understand the rave. I didn't understand it. Yeah.
Apparently comfort. Apparently, I have never tried, but it's again, it's the plastic and the rubber. The common footwear here is plastic and rubber, so nails go right
Wow.
through the outer sole, right into the insole. I've in the past 3 months, I've had 3 nail injuries because of poor footwear. So maybe that's interesting. The kind of clientele that I do deal with tend to usually not even be able to they struggle with even consultation and
Yeah.
for example even like a $10, $15 consultation would be hugely expensive to them. So now the two.
But yeah, it's a good alternative. So what are the differences you notice between diabetic foot care challenges in Kenya compared to other parts of the world?
Okay, again, I think it's the skin tone that makes a big difference.
Mm,
We look for redness, and we can't see redness in certain dark skin tones.
mhm.
It's not possible. And then when I was working in India, my biggest challenge was telling them not to go bare feet inside the house, to the extent where, okay, many Hinduism practicing people would go to temples and then get injured because temples are open spaces with lots of rock on the floor, right?
Okay.
It's a structural thing that we have in temples. Sometimes it's marble. Some of them are open temples, open to sky temples. So it's hard rock, and you get injured with one of those, or even nail injuries because you bump into a hard stone and all of that stuff. I think skin tone is one, barefoot walking is the other, and then patient education. But I think that also has to do with the clinicians. If the clinicians are not empowered to say at least 2 or 3 lines about diabetes foot when they are giving general patient education. You're going to tell your patient not to eat sugar or drink sodas or have juice or have honey, then you can also tell them to take a look at your foot before you go to sleep, and you can
Hmm.
tell them the changes that can happen. It's a 30-second diabetes education, the least you can do at every consult. It gets into their head and they actually do it.
Mm. So what lessons can high resource healthcare systems learn from diabetic foot care approaches in countries like Kenya?
Wow, that's a very good question. Dare I?
I think, I mean, honestly, I think just like what you said with the skin tone thing is a big, I've noticed a issue in certain places because I'll never forget one time I had this patient who had really bad PAD, like he knew, but the doctors who were seeing him previously were constantly shaving his calluses and he had like pretty much no blood flow and he was coming pretty much every 10 days. And I was like, it's because, and everywhere that he got shaved down, they were turning completely black. And I was trying to explain, it's the first time I saw it, I was like, it's because you have PAD, you know, and they were just thinking that was his skin color. And I'm like, no, that's not. That, like, he's beginning to get like localized gangrene in these areas. And it's painful because of the blood flow. So, I mean, I feel like that's something that a lot of people need to get educated about the different skin tone
Yes, yes, I
issues.
agree with that. I completely agree with that. It is hard, but then eventually I think we'll get there too. I maybe another thing that they can probably learn from us is there's a lot of red tape when it comes to referral pathways. So the referral pathways worked until they worked, and then I'm seeing that a lot of the referral pathways are also breaking down. If I have a patient who needs to, there's some patients. Usually, it's patients who fly out from here to wherever they need to go to get their surgeries. But sometimes when it's a simplistic thing, sometimes they just come here and get it done. Straying far away from the feet, dental treatment. Sometimes they just come here and get it done because they're like, it just doesn't work. You cannot, like, maybe in certain countries they're like, I cannot reach my dentist because, or my dentist says that I have to wait another 6 months for an appointment for so and so, etc.
Mm,
So similarly, I think even for diabetes foot, I think it is that screening doesn't have to, you don't have to wait for screening. You can just send a patient over to me. Like my colleagues send me patients and they say, doc, like they're diabetologists as well. They're like, do your foot screening. I'll do my foot screening. I'll send the patient back. There is no pathway in place to say you must see a patient only at this point in time.
mm.
I think that's something that probably the high resource countries can probably learn from us a little bit.
That's good because, yeah, insurances are like that. Insurances are like
Yeah,
that. Yeah.
yeah. I'm grateful that I don't have to work intensely with many of these insurances as such, but
Hmm.
yeah.
Yeah, because like,
I'm
mhm,
No, it could be bothersome. And in the public system, it's the same over here in Kenya, but our private systems are also very easily accessible, unlike in many high resource countries.
mhm.
So yeah, it we will see. Yeah.
Yeah, no, that was actually a brilliant point that you made just now, and I absolutely love it because, like, even with diabetic foot care, like, let's say we're clipping toenails as a podiatrist, if a patient toenails
Yep.
like grow faster, we have to document it and recommend that they come earlier than the 3 months so that they can be fully
Yes.
covered and not get this like huge bill that they come to telling us about next time. But it's
Yes,
just
yes, yes.
I love that.
Those are challenges. Those are really challenges. Yeah. No, like for example, I don't have a podiatrist with me who comes on a regular basis. So what I had to do is that I don't know nail care. I'm a physician. I got a nail file that we use to a fancy nail file that probably many of us as girls use or our nail techs use. And I'm buzzing nails down because I don't know what else to do. I mean, I'm doing.
Oh
I've
wow.
looked at tutorials and I'm like,
Uh-huh.
okay, we can do this. Thicken nails, we can just buzz them down a little bit until I'm able to get to a podiatrist who can actually take a look at it and advise if there's anything else to be done. Because it's uh, it's easy for me again
Mhm.
because I am in a country like mine. There aren't many people who have the scope to do only nail
Mhm.
care, or
Mhm.
there's nobody who says you cannot do nail care. It's a bit of a gray area, but at least
Mhm.
it's easy for me to provide that service for my
Mhm.
patients while they are here. And but I should also know what my limits are, and I do.
Mhm.
And I
Mhm.
should know when I need to involve podiatrists acutely and when I need to refer, because we don't have any podiatrists on available on in the public service sector. They're all private, and
Oh
private
wow.
most yeah, no, there's maybe there's none.
Oh
So
wow.
there are a handful of podiatrists here. There's five of them in all of East Africa. I think eight of them in all of East Africa. So that would include Kenya, Tanzania, Ethiopia. I might be misinformed, but these are the ones that I know of. So if
Okay.
that's the case, then I have to take that on to myself. I have to take that onus on me to do a little a tad at least, if not everything else, so that it doesn't form into another ulcer or whatever.
Oh, thank you.
But
Thank you
yeah,
so much. Thank you
no,
for your amazing service.
get
Like that's amazing. Oh no. uh, no, I I can't stand heat. I can't stand. I he can only do so much to me. I was like, oh, I I don't mind doing medical missions though. Gabby don't mind that. I yeah, but
noted.
what are
Yeah.
some common misconceptions about diabetic foot infections? I think we covered a little bit surface of that, but
Yeah. Okay. So the fact that if there are no local signs of infection, there is no infection. And also if there is, and of course people naming biofilms, it's one of my biggest pet peeves. They look into the wound and be like, that's a biofilm. And I'm like, you cannot see biofilm. It's not visible to the human eye. You can look for features suggestive of it, but no, you can't.
yeah.
But and then people who put individuals or with diabetes on constant or persistent antibiotics because there's a diabetes foot, because there are no
Mm,
local signs of acute infection. There's colonization and then there's infection. And to explain these at every forum that I engage in for such a topic, I usually tell them about it. That I tell it, and then I'm able to tell them to read a little bit more about it. But yeah, and then the antibiotic use,
uh-huh.
there's not much of antimicrobial stewardship. That's also something that is a challenge over here. Not over here. I think it's all over the world. But
Mhm.
I think it is a challenge that we do come across. It's a misconception that every diabetic wound needs antibiotics.
Yeah, no, it doesn't.
Also, yeah, and then when it comes to glycemic control, strict glycemic control, no carbs, etc. Nutrition plays a huge role in wound healing. So giving the right amount of micronutrients, mostly as much as possible, I try to advise foods, less processed foods that contain good amount of vitamin B12, etc., selenium, etc. But if it's not possible, then we give supplements. So there might not be enough evidence to give supplements, but there is evidence that there are micronutrient deficiencies. So I think it helps, but people do not understand. Good glycemic control does not mean laying off the carbs. It means that the patient does need carbs, but needs better glycemic control while being on the carb-filled diet and the protein-filled diet as well. Other than that, and offloading, the absolute
Mhm.
absence of the knowledge of offloading. Can't blame anybody about it, but I think that's something that everybody needs to look
No.
into for diabetic foot. Yeah.
Yeah, no, it plays a huge role, especially like they don't, especially if they have loss of protective sensation. You can walk on anything with loss of protective sensation and not know that,
Mm,
offloading. So that's very
mm,
important. So what's
yes.
one message you wish every person with diabetes knew about protecting their feet?
Mm, inspection and getting to know
Mhm.
your feet very well so that you can pick up anything abnormal. And of course, to make it a habit to inspect feet. White socks whenever you're wearing socks. I think
Oh,
those are
white
the
socks.
Yeah,
Am I
yeah,
correct?
because of neuropathy, they may not
Mm-hmm.
notice any callus bleeding. So
Mm-hmm.
when you remove white socks, you tend to look at any staining, any ooze that is new that you have not noticed or felt. If you look at your socks, if you're wearing socks and if you're looking at your socks, then yeah, you can pick up those things. Those are things that we explain as well. It was small little helpful tips. Yeah,
Mm-hmm. Where do you
I hope I've
think
answered the question.
no, that's that. Where do you think diabetic foot care needs the most innovation in the next decade?
How do we make offloading devices and practices more accessible and feasible,
Mm-hmm.
equitably? It's really important. It plays in regards to it plays a role in regards to prevention. Like I said, healthcare has to become more proactive than reactive. It needs to shift. The focus needs to completely shift. I also recently underwent a biomechanics training, and it has impacted the way I look at feet, bunions. I'm not a podiatrist, but like I said, I do the basics. I can do a little bit of this and a little bit of that, but it will impact how musculoskeletal abnormalities happen, even flexitinotomies, etc.
Mm-hmm.
Knowing about simple surgical techniques that can prevent long-term damage, lengthening of tendo-Achilles tendon where it is needed. Those are the things that innovation needs to come in and do. Come in and deep. I mean, innovation needs to be in those fields where we
Mm-hmm.
can make it easily accessible to anybody who needs it and not just to structured healthcare. Structured healthcare will take a longer time than clinicians being able to learn it and do the needful. So training, innovating. Yeah, yeah. Much
Okay.
less. Yeah.
And if you can change one thing about diabetic foot care worldwide, what would it be? I think you kind of just like kind of asked two questions the same but different phrases, but if you have another one,
Could you repeat that question? It's if I could change, if,
change one thing
sorry.
about diabetic foot care worldwide, what would it be? But we kind of covered it because you were talking about accessibility, knowing about the different procedures, and then also about what high resource areas with the referral system. So
Yeah.
you kind of covered that. So that's pretty much all the questions. So we're gonna go into the clinical rapid fire one. Yay. So
Okay.
these are
All right.
okay. Okay. So what's one word that describes limb salvage to you?
What's one word that describes
Limb salvage, yeah, in your opinion.
good limb salvage?
Yeah, good limb salvage. Okay. What's the
No,
first
I didn't
thing?
get the
Oh,
question.
no,
Sorry,
I'm
I didn't
so
get.
sorry, Laura. Okay, I'm gonna change it. What do you think is the most underrated part of diabetic foot care?
Offloading.
Yeah. Right.
Yeah.
What is your favorite offloading device then?
Oh, I use Crown Orthotics or I use MCR's microcellular rubber.
Oh, okay.
That's what's accessible to me. Yeah. I don't have a choice. These are
Uh-huh.
both my favorites.
No, I know, I completely understand. I know exactly what you mean.
Yeah.
What's the first thing you look at when a patient with a diabetic foot ulcer walks into your clinic?
I look at their face with a big smile and I say, "Hi, how are you? How can I help you today?" No, but glycemic control is extremely important and social support. What kind of social support they have?
Oh, you know what I forgot to ask? What about how's vascular there when it comes to that approach?
So vascular, we do have access to vascular. Remember, I'm in the capital city. Nairobi is the capital city of Kenya. So I do have access to, but again, the costs are very high and they're
Mm-hmm.
not completely covered by the universal health coverage as part of the universal health coverage. It's partially covered. So clients decline to undergo intravascular procedures in a lot of the cases because of affordability.
I actually had the exact same problem when I was in my
Yeah.
home country. Exact same problem, like $400 just for a consultation, and I was just like, "You're joking, right? You're not doing anything. You're just looking at the person. Yeah,
Yeah.
that's crazy. And if the whole point is to serve and help save limbs, it shouldn't be that cost. Like, why would you make it that expensive? Okay, it didn't make sense to
Because
me.
they can. Unfortunately, because they can, because they are few and fewer. They're very few, so they
Hmm.
can. They keep
Yeah,
it commercial with it and they can take advantage of it.
yeah,
It's
it's kind
not
of
odd.
a abuse. No, but it is a abuse, you know? It is a abuse of the healthcare system. And yeah, we get it. You commercialize yourself. Yeah. But you try to save a limb and make it accessible. 'Cause honestly, even on my side, when I was trying to go like just around, I had a person, like a person of who's like had a clinic tell me that they don't need like my services because their patients were like affluent. Like, they were like, "My area is more, like, underserved," and they didn't have,
What?
like yeah, I actually experienced that. They're like, "That's not my our population, our population is more affluent," and, he was like, "Okay, there more of the people that, need this wound care is more," you know? I was like, "Oh, interesting. I did not know you saw it like that." But, it's very interesting how certain people see it.
Yep, 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 yep. It's unfortunate, but it's interesting. And then this is where it becomes easy for me to do procedures that are not entirely part of my docket, but I make it my scope because you know what? I need to provide patient services. And if it's going to help my patient and if it's not going to harm them, then yes, a few things I will have to do, like offloading, like nail care.
Mhm,
I do not expect my patient to go and spend another few $100s. I'd rather them spend on healthier food rather than, or even medications, rather than
mhm,
do a consult just for formality's sake. I will tell them and you explain to them and then you tell them to make a choice whether you want to continue here or would you like to explain.
yeah,
So informed decision making, it helps. But yeah,
yeah,
it's flabbergasting in countries like ours sometimes where care can only be accessible to certain people. It's not equitable at all. And I think making that is it would be a dream come true for me, honestly.
yeah.
It would be so nice.
I do have another question because I feel like this is very important. So, what would you say when a patient, like in a low resource country or anywhere, to be honest, because not the economy is very interesting, fluctuating right now. When, self treating is a big thing because people try to self treat before going to the doctor because they're trying to save money and it's a diabetic patient, it starts off with something simple as a callus and they want to shave it down themselves because they don't want to go to the doctor because they don't want to get this bill. What would you say to that patient to encourage them to just go in?
I would probably explain the health economics behind it. I would say that you would rather come to us for a single consult. We do it professionally, whether it's nail care or whatever the case may be, and we we help you out before you do bathroom surgery, and that would cost you another 15 or maybe another 20 days of having to leave work, leave a working day. Come, you've lost the money, you've paid money for
Mhm,
transport, you have spent money on dressings, etc., etc. So you have to explain the health economics aspect of it and tell them, look, you do one thing wrong, and that's going to be nail bed infection, which will progress into one, it's a heavy economic burden. Two, you may even lose your toe.
mhm.
So please no bathroom surgery. If you see a blister, if you see an infected toenail, please come to us. We'll sort you out faster than you possibly can think that we do. And luckily, in the hospital that I work with Lionside First Eye Hospital. We our 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 fee structure is quite affordable and it's equitable. It's
Mhm,
not the cheapest, but
mhm.
it is also very equitable. We are on par or even less than public health services in certain instances. So I think I diverged from the question. Your
No,
question
no,
was about no, but yeah, I
no.
mean, yeah, I wish. What was your question again?
No, it's fine. It was just about like the self treating, and you were actually making a great point. Yeah, yeah. You yeah, you actually have been spitting out some really amazing facts and some really cool taglines, like "Look at your feet before they sleep," and then this bathroom surgery. I feel like you need to make a book because I love the taglines. I love it. I love it. I'm totally for it.
Take it. Sorry. Yeah, because it's easy for patients to remember, and they laugh, and they'll be like, "Oh, doc said that to do this." So then you're like, "Okay, it sticks." And then
Yeah.
sometimes they listen. And I mostly get elderly patients, so you call them good boy, good girl, and they laugh. They'll be like, "Oh, this is the doctor that calls me a girl or a boy instead of calling me an elderly lady or a woman." And then they kind of listen.
Yeah, yeah. What's one lesson Kenya has taught you about medicine?
That it is. not impossible to collaborate with like-minded people, but you have to be consistent enough to look for them and find your tribe and find people who have a similar mindset to yours. If
Mhm.
it's limb salvage, it's about people who care about patients. It has to be equitable. It should not drain you, but it should also not drain the patient in any way possible. Collaboration is not difficult at all. I have several colleagues that I work together with who have a similar outlook to how we manage diabetes foot, and it's such a
Mhm.
pleasure to work with them. So, but we just have to be consistent with looking for that. We can't give up. It's not giving up is not an option for our patients. Giving up should never be an option. Just need to keep at it and find that person that you can collaborate with. Yeah,
Yeah, well, output plays a huge role in that. Like, that's kind of like where I found my tribe is
yeah.
in Alps. Yeah, I did not find it in my home country at all. So, yeah, I completely
You
love
will.
that.
You will.
Uh,
No, you will. You will. Yeah.
okay, and what's one place in Kenya everyone should visit?
Nairobi. Nairobi.
Nairobi.
Then of course. Yeah. And then the Mara, of course. The Mara is extremely important. You cannot miss the Mara. And Mombasa, our beaches are beautiful. Would I love my beaches.
Hmm. Wow,
The sea is
awesome.
amazing here. Yeah, yeah, yeah. I love my country. I absolutely love this place, and I welcome anybody who'd come. It's a nice place to be. Challenge anybody who stays here for more than 3 years to want to go back to their own home country, and I usually win. Most of the
Oh,
times we like staying here. The weather is amazing. People are pretty, very, very fun people. There's a mix of culture. There's a mix of culture. There's a mix of everything. I like it. I really enjoy living here.
awesome. Last one.
Yeah.
What's one word your colleagues would use to describe you?
I want to say ADHD, but maybe not. I would say I've been called a butterfly. I've been called
Aw.
busy bee. I've been called because I keep moving between rooms. So if I'm going to take a video and send it to you, Gabrielle, just to show you
Mhm.
what my clinic looks like. But yeah, but I keep fluttering between things and making sure that everything is sorted out. I'm not always successful, and I'm okay with that. But yeah, I can't stay put. I'm everywhere.
I love how you're just like passionate, like you said, a little busybody. So you're always doing something, but that means that you will accomplish something. You're not just
Yeah.
sitting around, you know, you're actually proactive. Actually, you are proactive in this whole movement of limb preservation. So that's beautiful. Okay.
Thank you. No, no, I get inspiration from all of you all out there as well. I feel like there are so many of us that are doing so much work. It's just that I think to kind of cheerlead each other into doing more and more and support each other in whatever we can, it, it will be so impactful for our patients. At the bottom line is always the patients, and it will be significantly impactful for them. There's one thing.
As we
Thank you,
conclude,
Gabrielle. Really, really.
as we
It's
conclude
fun
today's
talking to
episode,
you.
I isn't it incredible talking to you? I feel very kindred with you. And
As do I. I was really nervous about this, and you made it so easy. Yeah, thank you.
as we conclude today's episode of Limb Watch, I want to extend a sincere gratitude to Dr. Shilpa Mulki for sharing her remarkable expertise, experience, and unwavering commitment to limb preservation. Her work is a powerful reminder that innovation is not defined by the resources we have, but how we adapt, how we collaborate, and remain steadfast in our mission to provide the best possible care for every patient. And thank you, Dr. Muti.
You're very welcome, Gabrielle. I am grateful to you that you have this podcast. It is impactful. I've listened to quite a few others, and I have learned quite a bit. So, congratulations to you on this podcast. And I hope that you host many, many more and educate many, many more.
Oh, thank
Thank
you
you for having
so
us.
much.
Yes, they do